Hello, future LPNs. This is Mrs. McBride, Professor McBride, is from the NUR 160 class. We're going to be reviewing this part two of perfusion. So hopefully you've seen part one. Today we're going to be actually talking about blood pressures and how perfusion affects that. And then also with heart failure, because you'll be seeing that a lot in your clinical practices. Heart failure, unfortunately, is one of those conditions that we see a lot, as well as diabetes, and of course, high blood pressure. A lot of times, high blood pressure is the reason why people end up in heart failure because they don't control their blood pressure. So it's very important for us to know how to interact with this, how to recognize it, and to understand the processes that go along with perfusion. So this is your week 8 lecture 2. Please make sure you've watched week 8 lecture 1 that's also on YouTube. It's also found in SurePath, so check your SurePath. Make sure that you've looked it at. And the URLs or the links are there for you for all of the lectures that you may have missed. Well, the anatomy and physiology of blood pressure regulation, it's a multifaceted topic. Blood pressure, of course, is the force exerted on the walls of the blood vessels, and it primarily affects the arteries. It's determined by two main factors. As you know, that there is systolic as well as diastolic pressure, and those are both. So again, two processes control our blood pressure. Our systolic pressure is that highest number. It is the number that we call the systolic, and it is usually normal around, somewhere around 115, 120. Uh, we'll tolerate up to 130 with our older adults to 135 at most. And then we have our diastolic, and that is the lower pressure recorded when we listen to the heart, to the blood pressure. And it is where the heart relaxes between beats. And this represents the residual or pressure left over from pumping that blood out of the heart in through the aorta and out to our body. So if those pressures are high and remain high or remain unchecked, then that puts a stress on our heart. And that stress on the heart is what causes the heart to enlarge. And of course, it's easy to control our blood pressure. It just takes a little medication. We tell, tell people to make sure that they're taking their meds, make sure that they're taking the proper amount, and that they're monitoring their blood pressure from time to time. Of course, anger, stress, um, too much caffeine are things that are going to raise our blood pressure. So again, those two pressures together provide a comprehensive review of the cardiovascular system's function. And what does the mean arterial pressure? Now that's the MAP. Mean arterial pressure is the average blood pressure in the arteries throughout one cycle. And the mean arterial pressure is a key indicator used in our clinical assessment to judge the amount of blood flow and whether or not we're getting enough perfusion to our organs and to our brain. It is calculated from the systolic and diastolic pressure readings and provides a more comprehensive view of our blood pressure than just looking at the blood pressure alone. For the MAP, it's essential for ensuring that the organs are receiving enough blood flow to meet their oxygen and their nutrient needs. It takes a map of at least 60 millimeters per mercury in general to consider it necessary to maintain adequate blood flow to the organs as well as our brain and kidneys. Our normal range, again, 70 to 110 millimeters of mercury, again, calculated by looking at diastolic plus one-third systolic. Depends on elastic properties of the arterial walls, depends on whether or not we have too much stiffening, or if it's too relaxed, etc., in order to judge the mean blood volume. The difference between systolic and diastolic pressure, typically 40 to 50 millimeters of mercury, this pressure is related to the arterial wall stiffness and stroke volume. And we look at the pulse pressure difference because that tells us some very important things, especially if there's a widening pulse pressure. we know that there's something going on with that patient, and we need to be looking closer at our vital signs and what's going on with them if the diastolic is real low and the systolic is very high. Um, okay, what controls our blood pressures? There's multiple regulatory mechanisms that go on. Not only does our kidneys make a play at this, but there's specific baroreceptors, which are specialized nerves in our carotid arteries and aortic arch that senses the changes in our blood pressure and sends this information back to our brainstem. When the blood pressure decreases, the baroreceptors accelerate the heart rate. That's why I said always the body is trying to stay in balance. And so it will increase blood pressure by increasing the heart rate or decreasing the heart rate in order to kind of control that. Again, it increases the myocardial contractility and it constricts or makes smaller our arterioles by raising that blood pressure. When the blood pressure increases, baroreceptors increase parasympathetic activity and decrease sympathetic activity, dilating the arteries, decreasing the heart rate and contractility. So let's talk about, you've heard us talk about cardiac output. Again, cardiac output is our heart rate times our stroke volume. And this represents the amount of in pressure in blood that we are pumping out of our heart with each heartbeat to affect that pressure that's going through to our body. And there's a number of factors that can affect our cardiac output or CO. It's preload, that's the fluid volume and venous constriction. Contractility, that's the force of the heart and the muscle contraction. And then our heart rate, that's the sympathetic and parasympathetic balance. Peripheral resistance, factors affecting that is the arterial vessel wall is a primary determinant. It's controlled by the sympathetic nervous system. And we have alpha receptors that control vasoconstriction, beta receptors that control vasodilation in our skeletal muscles. So, and of course, blood viscosity. Most people know their blood pressure, but fewer understand blood viscosity. That's the thickness and stickiness of the blood that influences how easy it flows. Of clinical significance, blood pressure regulation maintains adequate tissue perfusion despite interferences such as blood volume changes, changes in body position, environmental influences, etc. When regulatory mechanisms fail or become imbalanced, then we end up with conditions such as hypertension or hypotension. Hypertension, elevated blood pressure. Hypotension, low blood pressure. And so we have some potentially compromising tissue perfusion and organ function. Think about if the blood pressure again is too low, then there's not enough blood being able to drive our kidneys. Remember, our kidneys are dependent on that blood pressure level being at the proper level. If it's too high, then it may be overloading those same systems and may be causing too much pressure and stressing. So those are things to think about. So what is optimal blood pressure? Williams page 371 is a good review for you. If you don't know about what we're talking about with the optimal blood pressure, make sure you take a look at that. Again, we don't want our healthy adult we want them to be around that 120 over 80 millimeters of mercury. A pressure over 120 over 80 or below 90 over 60 is considered abnormal. And this is by the joint group of cardiologists every year get together. Every few years internationally, they get together and they look at the cardiovascular information. Now, our blood pressure rates and levels have changed from time to time in the past, and they have now optimized this to say we really need to be keeping people at 120 or 80 or a little bit less than that. So even 110 over 70, 105 over 70, those are going to be okay blood pressures. With our older adult, as they have less ability to have elasticity in their blood vessels, their blood pressure is going to rise slightly. And so it may be about 130 over 80 or 130 over 85 is what we're going to see in our older adult. And that actually is a little bit high blood pressure. As of 2025, the target blood pressure standard is set less than 130 over 80. And that's for the adults. That's the guidelines that we've received from the international group, JNC, that looks at blood pressure and cardiovascular health. And they have said that we need to be teaching our patients to keep their blood pressure less than that level. It's always wise to first palpate the artery to detect what level on the manometer no pulse is felt before taking the blood pressure of an older adult. So when we put the blood pressure cuff on them, we should be feeling the radial pulse and then pumping it up. And when we no longer feel that pulse, that is what we note as to be the systolic level of kickoff. That's where we want to we know that we need to just pump it up just a little bit above that in order to check blood pressure. Sometimes we are always pumping that blood pressure cuff up to 200 or 210. It may be too high for some of these patients, so we're ending up with inaccurate blood pressure levels. Many older adults with hypertension have an oscillatory gap in their Kirchhoff sounds. If you simply pump up the cuff until you do not hear any sound and then let air out of the pump cuff, you may miss actually the upper point of their systolic blood pressure. You may have not gone high enough if you don't, again, hear. Check to see the patient's baseline blood pressures. Ensure that the blood pressure is recorded for the correct person. Knowing the baseline blood pressure assists in knowing how high to inflate that blood pressure cuff. I know you've gone over blood pressure in the last term, but again, perfect your ability to take blood pressures. It's very important. A lot of times as a nurse practitioner, I'll go back in and I'll check my own blood pressures on my patients because it's not that I don't trust. It's just that sometimes machines and people don't really do it accurately. Sometimes we're using too large of a cuff on a patient or we're using too small of a cuff. The cuff should fit appropriately the diameter of the arm, and the person needs to be sitting. It needs to be in the right position between the elbow and the shoulder. And we need to make certain that if we're using an electronic cuff or a wrist cuff, that we're putting that cuff up on their chest so that it's at heart level. So those are important things to consider. Do your vital signs accurately, please. So let's look at some blood pressure disease and testing that we do. Electrolyte panel. Again, we're going to be doing, sometimes we'll do a CBC, and that's to check to see if the patient has adequate blood production, making sure they're not anemic, making sure that the hemoglobin and the hematocrit and the red blood cells are intact, that they have good platelet counts. And then we'll also look at the electrolyte panel. Of course, the electrolytes, we've just got through going over that. That's sodium and our potassium and our glucose, BUN and creatinine, and calcium. We're looking at all of those wonderful electrolytes. Magnesium, calcium, we need to be noting as well. CRP, that's reactive protein. That's a test that detects inflammation in the body, which is associated with cardiovascular diseases, including hypertension. Elevated CRP levels may indicate a higher risk of heart problems, and that's the reason why we look at that particular product. Then we've talked about basic metabolic panels, BMP. That's that function of again, BMP is the basic metabolic panel that has our electrolytes in it. The next one on your list here, though, is not basic metabolic panel. It's beta natriuretic peptide. And someone has made a boo-boo here, so we'll correct this on the slides. But BNP is actually a blood test that tells us whether or not that patient is in heart failure. BNP is not basic metabolic panel. It's beta natriuretic peptide. And I will correct that again on your slides and reestablish those slides. But the basic natriuretic peptide, there's also another test called a pro BNP that's more accurate, that tells me if that my patient has congestive heart failure. The higher the pro BNP is, the more it indicates that that patient may not survive for very long. It tells me if it's over 3 or 4,000 on our list, then now, the BNP is a lower number. If it's above 400, definitely that patient is definitely in heart failure. We consider anything below 100 to be normal, but again, it's mildly elevated 100, 200, 300. We may not change our treatment plan for that patient, but if it's above 400, definitely I'm looking at their weight and looking at other values. Urinalysis, checking the urinalysis on a patient, electrocardiogram. We're going to be doing that to check their heart rhythm and make certain that it's. So I've corrected this real quick while I took a little quick break here. Sorry about that, but I did want to make sure that we corrected this slide. The electrolyte panel, I've added BMP and CMP to that, and then I've also updated the brain natriuretic peptide, BNP, and the NT-Pro BNP, because I wanted to make sure that you were aware that there are two of those tests. One, again, both of these indicate heart failure, but they indicate the severity of heart failure and those patients that would benefit from being intervened with at a higher risk, that they're a higher risk for that heart failure. That's what the NT-Pro BNP tells us. Of course, then we have urinalysis and we have electrocardiogram, and those are, you'll learn more about electrocardiogram next term as far as learning the waves and what everything tells you. It would not hurt for you to get a little bit of ahead of that a little bit, especially during Christmas break. Doppler ultrasound, again, we use that to tell whether or not the person has DVT. We use Doppler to look at DVTs in the upper extremities as well as the lower extremities. And then, of course, chest x-ray. Chest x-ray will tell us whether or not the person has atelectasis, which is basically, does the person have the lungs collapsed a little bit, or is there fluid in the lungs? And that can help us determine a difference between heart failure versus pneumonia. So for some very important diagnostic testing. So hypertension, again, is elevated blood pressure. It's the leading cause of death globally. Again, normal, according to JNC7, is 120 over 80. That is where our optimal, where we would want our blood pressure to be around that level, nothing too much higher than that. And there's two types of blood pressure issues. There's primary hypertension. Now, primary hypertension, that is just having a higher blood pressure, and it's not caused by, it's just caused by our genetics or by our, are we overweight? Do we have diabetes? Do we have other things going on? But then secondary hypertension, like secondary, when we run into the word secondary, automatically think, oh, is something else causing this? Is this related to medications that they're taking? Is it related to another condition that may be worsening their blood pressures? So blood pressure above 140 over 90, that's considered to be what we call secondary hypertension. What is the difference there? Primary, again, majority of all cases are primary. Secondary, that happens when there's another medical diagnosis involved. That would be like kidney disease, kidney problems, diseases of the adrenal cortex, which sit on top of the kidneys. That cortisol, when it secretes, if it's too high of a levels, it can mess up our blood pressures. It could be because there's stenosis or narrowing of the aorta. It could be due to also a head trauma. And of course, we've all heard of pregnancy-induced hypertension, which is not a good thing to have if you're expecting a child, especially in that last trimester. So most people, the reason why they don't treat their blood pressure is because they don't have it doesn't really cause too much bad feelings. They may not even know that they even have high blood pressure. They may not realize that their blood pressure is 180 over 110. They may feel a little kind of overwhelmed, or they may be feeling a little bit that there's something there on, just in the background, but not too many people really realize it's blood pressure until it's caused some issue. So we definitely need to be checking blood pressures every time that patient comes into the office so that we know exactly if there's any changes. If the high blood pressure may also have may be associated with headaches or shortness of breath, or they may be having nosebleeds. The body is trying to tell you something if you're having a nosebleed and your blood pressure is high. These symptoms aren't specific, so they don't always cause a person to actually seek medical help. So let's take a look at overview how hypertension affects the major organs. Again, this is a very busy slide. It starts with hypertension at the top. Then we have our heart, kidneys, brain, and eyes. As you can see, the heart, as the heart disease develops, and we have more higher frequency of sustained blood pressures, then it causes the left ventricle to work harder because, first of all, the pressures in the body are higher. Therefore, it's backing into the heart, causing it to have to work harder. It leads to higher pressures in the lung. Now we're not getting filled as quickly or as easily, and so left and right sides of the heart may be affected, which can cause hypertrophy. Hypertrophy, hypertrophy, which means enlargement. And that can lead to heart failure because our heart gets floppy. It doesn't want to beat as well. As you can see here, you've got increased arterial pressure. They got the hypertrophy listed there with ventricle failure. It can cause weakening of our blood vessels, which can lead to aneurysms. That's the reason why we have issues. I mean, our blood vessels have a covering over the outside, then it has a inner intima covering, and then it has the inside. And they're usually, I mean, they're pretty tough little tubes that carry our blood. They have to be because of the pressures. Now, our veins don't have as much structure to them, but when they get overflowed, they can actually cause the aneurysm. It causes a rip inside the blood vessel, and then it causes an outer pouching, which is the aneurysm part. It's like a balloon forming. And if that were to burst, especially in the aorta, we've got some problems. And I worked in surgery. I've had patients that have been flown in via lifeline, and we've done surgery on them in order to clamp that aneurysm when it was bleeding. Not very many of those patients survive. So it's very important for these people, they're usually in their 40s and 50s, they're younger, to take care of their blood pressure. So kidneys, if we have atherosclerosis, which is narrowing of the blood vessels because of fatty deposits and cholesterol, that can cause narrow arterial lumen going into the kidneys, which is also going to decrease the amount of pressure going into the kidneys. And remember, I said the kidneys are dependent on the blood pressure coming in for their ability to be able to filter urine. And if that blood pressure isn't the right level, then it can have problems. Too high a blood pressure can cause the kidneys to be overstressed and too much pressure going into them can actually cause damage to those nephrons, which is the functional part of our kidneys. If we have too much pressure going into our brain, it can cause constriction and damage to the cerebral arteries in our head, and that can increase our risk for transient ischemic attacks, TIAs, and cerebral vascular accidents or strokes. Eyes, oh gosh, narrowing of the retinal arterioles, retinal hemorrhages, papilledema, all of those can lead to blindness. So, yeah, our blood pressure is pretty important to control. So let's look at hypertensive crisis. Hypertensive crisis is a blood pressure higher than 180 over 120. Mark that. You may want to know that. Again, 180 over 120 is considered a hypertensive emergency or crisis. Untreated high blood pressure increases the risk of heart attack, stroke, and other serious health problems. Besides the normal high blood pressure symptoms, the person may have tachycardia, tachypnea, which is fast breathing, seizures, and cyanosis, which is the bluing of the fingers and the toes. So again, watch for extremely high blood pressures greater than 120 over 120 millimeters of mercury, but extremely high 180 is what we're looking at. So you'll see patients with headaches, drowsiness, confusion, blurred vision, the changes in your neurologic status, dyspnea. They may become, first of all, angry or have outbursts because they're not for sure what's going on. They have this feeling that something's not right. They know something's wrong. They can't quite put their finger, and they may feel like they're doomed. They may tell you, "I feel like I'm dying." So be aware of that. Make sure that we watch that. Make sure that we're evaluating and that we're getting those blood pressures as we need it. So, what are our hypertension medications? We want to treat this, we want to get it down. Our first medication that we sometimes typically treat blood pressures with is diuretics. And then we may put an ACE inhibitor or an ARB, which works, which is our angiotensin 2 receptor blockers, or our ACE inhibitors. That's going to be your lisinopril, captopril, enalapril, and then our angiotensin 2 receptor blockers, if they don't tolerate ACE inhibitors, then we are sometimes putting them on valsartan, Cozar, Hyzar. That would be those medications. What is interesting is that we have to also be respectful of a person's genetic history as well as their ethnicity when treating their blood pressures, because different people may not tolerate, and the first choices of medications may not be the right choices given their genetic. We need to treat people according to their specific needs, not because a book tells us. Historically, we use two or more blood pressure drugs that work in concert in order to get that down. Again, it's a diuretic plus our ACE inhibitor or ARB. Well, historically, it has been indicated that Black people do not do well with many hypertensive medications. That's really no longer the standard. We're needing to make sure that we're treating each patient and trialing these medications. So you may put a patient, if you're in the clinic, you may work for that doctor. They're putting that patient on. Then 2 weeks later, they're bringing them back in to have their blood pressures checked to see, is this medication working the way we want it to work? Is it working in concert with them? Then we may need to tweak something if it's not. So again, we're needing to make sure that we're assessing the action of that medication. So calcium channel blockers, beta blockers, vasodilators, alpha blockers, and alpha 2 receptor blockers. You may want to kind of memorize this list and then put some medications behind it so that you know which medications belong to which one. Again, diuretics, those are our thiazides, usually hydrochlorothiazide, diazide, which is our first most common diuretic. And then again, we have to also watch the effects of some of these medications because they can also lead to some electrolyte imbalances. So we commonly have to watch that. Again, Lasix, Bumex, torsemide, and amiloride, and then hydrochlorothiazide are usually prescribed diuretics, aldactone and eplerenone or Enspra. Our ACE inhibitors. Okay, if you've got a copy of these notes, make sure you're reviewing these medications and getting them on your 3x5 cards. Extremely important for that HESI coming up, okay? Lisinopril, Prenavil, Zestrol. Those are often prescribed for high blood pressure. Now, remember that captopril and enalapril and lisinopril, they have that nasty, nagging little cough that's sometimes associated. Now, that doesn't say that this person shouldn't be on that med, but if it becomes nagging to the point where it's constant, then maybe they need to go to an ARB instead of the ACE inhibitor. We want to make sure that we put them on whatever works for them. The angiotensin 2 receptor blocker, again, that's the ARBs. Those medications work in combination with those again, and valsartan and losartan are very commonly prescribed. And those medications work by blocking the action again of angiotensin 2, which helps relax blood vessels and improve blood flow. So they reduce the workload of the heart, and it's also prescribed for heart failure as well. So when typically our standard of care for heart failure is put them on an ARB or on an ACE inhibitor, as well as put them on diuretics. And then we're going to also look at a beta blocker for that patient. Remember, the beta blockers are those medications that have LOL after them. We don't always assess the beta blockers, but we want to make sure we're assessing because beta blockers, metoprolol is cardioselective, whereas Coreg or carvedilol is not cardio or beta receptive reacting. It will hit the beta 1 and 2, whether it's in the heart or if it's in the lungs. And so some of your COPD patients may not be tolerating that particular beta blocker. So it's very important to be recognizing that. Then we have calcium channel blockers. That's amlodipine, Norvasc, diltiazem, which is cardizem, verapamil. And cardizem and verapamil are also used for migraine headaches. Norvasc is sometimes added on as the third part of a blood pressure medication treatment, and amlodipine above 10 milligrams per tablet can also cause a little bit of ankle swelling. So we need to be assessing these patients for ankle swelling because that may be due not to heart failure, but to the action of the calcium channel blocker. So we try to kind of keep that at 5 milligrams or less. We don't see that swelling to 10 milligrams, and then we do. So that's something to be watching for. Calcium channel blockers restrict the amount of calcium entering into the cardiac and smooth muscles. And that, you remember, calcium is important for muscle contraction and relaxation. If you don't have the right amount of calcium in there, you're going to have problems with that, okay? So it causes the blood vessels to relax and widen or vasodilate. It improves oxygen supply to the heart, and it lowers blood pressure. They should not be drinking grapefruit juice with this. This is one of those things that grapefruit is typical. It sometimes changes the way medications are absorbed. And so it can either increase or potentiate a medication, or it can actually block or keep a drug from being able to work as well. So we need to make sure that we tell our patients don't drink grapefruit juice. It will increase blood levels of certain calcium channel blockers, which could be dangerous. Vasodilators, that includes hydralazine and nitroglycerin. Those help blood vessel cells to relax and widen as well. We give nitro with myocardial infarctions, and that's very important to be aware that it will cause the blood pressure to actually drop, and sometimes too much so that the patient may have a headache, rapid heartbeat, and lightheadedness. So we need to be checking their blood pressure if they're on the vasodilators. We also have alpha blockers and alpha 2 receptor blockers. So there's a lot of medications that go into these medications, a lot of for heart failure. So hypotension, low blood pressure is called hypotension, and that is a pressure less than 90/60. The MAP on that's going to be right at 60. So that's the reason why we look at that one. With hypotension. Hypotension sometimes has this, the system of shock. If it's too low, it will look like they're volume underload or circulatory collapse. And that's a dangerous condition because it can really progress to death really, really quickly if we don't get it treated. Shock is caused by hemorrhage, vomiting, diarrhea, burns, and myocardial infarction. So that is the reason why it's important to also be checking for our blood pressure levels on patients. Signs and symptoms, these patients will be cold and clammy. That's diaphoresis, is that the damp, cold skin. It's the sweating. They'll have apprehension, dizziness, blurred vision, and their body trying to compensate will increase the heart rate. So that will also indicate that this person might be going into shock. So orthostatic hypotension, we've talked about this a number of times in different with different lectures. That's the sudden change in blood pressure when we have a change of position. This can be from laying down and sitting up to standing. So it's very important that we look at their blood pressure and see if there's a drop in or change in their blood pressure by 20 millimeters of mercury. That's our gold standard, 20 to 30 millimeters. If we see that, then we can call that orthostatic hypotension. And how do we check for orthostatic hypotension? Make sure you look at Williams, page 372. The older adult often experiences orthostatic hypotension with a drop when rising to standing because the elasticity of the blood vessels decrease with old age, meaning that their blood vessels don't constrict when they need to in order to support the blood pressure, which is a normal process. We stand up, and our blood pressure is supposed to go with us. But sometimes the blood pressure says, "Oh, we're standing? Really?" And it doesn't support the person. And then they end up having orthostatic hypotension. They get dizzy and then they fall. So, again, tell people to change their position slowly, to sit for a few moments, do some ankle pumps, do some deep breathing before they stand up. And then that will keep them from being on the floor. So, what is the physical exam by the healthcare provider? It is to look at those signs. We're going to be measuring their blood pressures at home. This helps give us a baseline because sometimes people have white coat syndrome. And so we'll tell them, take your blood pressure at home. Take it while you're at work. Take it, when you're before dinner or after dinner or before bedtime, when you get up in the morning. Bring me some readings for the next 2 or 3 weeks. Now, if they remember to do that, it's great. And then we also can do some blood tests to indicate whether or not they have low blood sugar as well. If that's what's causing this, hypoglycemia can cause them to get dizzy. High blood sugar, also called hyperglycemia, can also cause some differences. And then, of course, low red blood cell count called anemia. We'll look at the electrocardiogram or ECG. This is a quick way for us to check to make sure that there's no arrhythmias or any changes in the person. And then we can also put this person on a tilt table. A tilt table test tells us how the body reacts to changes in position. We put the patient with a blood pressure cuff on their arm, and we put some monitors on them, and we strap them to the special bed, and then we change their position and do readings while we're moving them, up and down on this bed. It mimics the movement from lying down to standing up. The straps hold the body in place, and the heart rate and blood pressure readings are tracked during the test. After laying flat for a number of minutes, the table will be tilted to a position that mimics standing. And we can watch how the heart is reacting and how the nervous system is responding to the changes in position. So, hypotension treatment. Low blood pressure without symptoms or with only mild symptoms rarely require any type of treatment. We'll just tell the patient to make sure that they're keeping their fluids, making sure that they're measuring their fluids well, making sure that they're getting plenty of that, making sure it's not their low blood pressure isn't due to volume. If everything looks good with that, then we'll just try to make sure that they're not anemic, they don't have anything else going on. That will give them some hints. Make sure that they're eating correctly. Make sure that their sodium is in a good level. Make sure that they don't have issues. Now, remember, sodium sources, of course, sauerkraut, canned foods, cheeses, canned fish, canned meats. Olives, unless they're really well drained or they're natural, then we have some salt in there for preservatives. Of course, canned vegetables, they're all preserved with sodium, so they need to be able to watch their sodium content for those. Um, they may need to eat more salt. So we may recommend if they have low sodium with low blood pressure, we want them to eat these things. If they have high blood pressure, these are the things we tell them to avoid. So we want to make sure that we do some assessments, do some blood levels first before we put them on any type of dietary changes. Wear compression stockings. That helps improve the blood flow so that the blood is not staying in the lower extremities. And we can sometimes also tell them to use compression belts that are around their middle of their body. That's almost similar to the same type of pressure suits that pilots wear when they're in jets going up to high areas. If they're going to a high altitude, their pressure suits will increase their pressure on their body to increase their blood pressure. Otherwise, they pass out. So we've learned a lot from different areas. So that helps. Then, of course, there's medicines that treat low blood pressure. If a person has continuous low blood pressure, where it drops to the 90 over 60 or lower levels, there is a drug called midodrine, midodrine. And that is prescribed to help with blood pressures and to help lower that out. There's a patient can take that once or twice a day, but nothing too much more than that. And we'll see patients that are having dialysis on their dialysis days. Sometimes they'll give them this, especially if they're experiencing low blood pressure during dialysis. So hypertension treatment. Now that's going to be our avoiding our sugary foods and salty foods and making sure that we're limiting all that salt and stuff. As long as their sodium is in the normal range, then we can tell them to limit some of that, to eat more fresh fruits, vegetables, whole grains, lean protein, and make sure that they're getting exercise and drinking again good fluids, staying away from the sodas, staying away from the carbonated drinks. Again, the Healthy People 2030 goal is to attain a healthy, thriving lives and to prevent disease, disability, and injury and premature death. So that's our goal right now till 2030 is to help people find a better balance and help them choose wiser food choices, exercise, and getting plenty of rest and sleep. So our collaboration, we do collaborate with quite a few people. We're going to be collaborating with our pharmacist. We're going to be collaborating, of course, with our um, doctors and working on primary prevention and secondary prevention. So education, education, education by doing controllable, modifiable risks. So we're going to tell them healthy diet, stop smoking, exercise. If they have venous stasis, to wear, of course, some type of TED hose or some anti-embolism stockings of constriction stockings. Make sure that they're getting at least a nice, good, brisk walk a day. We're going to tell them about how to prevent illnesses, early detection, make sure they're getting their vaccines and that they're staying healthy, and to take their medication, and then to also get screened. And screening and early diagnosis is paramount into increasing our longevity. So, routine screening involves monitoring our blood pressure and our serum lipids, and then to make certain that we are keeping our weight in check, that we are also watching what we eat, eating healthier lifestyle, and eating less salt if that's what we should be doing, and making sure our sodium, potassium, and our electrolytes are, in limits, and getting 7 to 9 hours of sleep is very important. And promoting home blood pressure monitoring, teaching patients how to take their blood pressure correctly at home as well. So let's talk heart failure. Heart failure develops when either ventricle, left or right ventricle, fails to pump efficiently. It can develop in response to a weak myocardium or heart that is unable to pump blood. Now, review your Giddens page 450 for heart failure. Again, there's a YouTube here, and I know how these YouTubes work. I'm going to tell you, go to this and take a look at this. It's not that long. It goes over heart failure, and there has been other videos that are out there on heart failure. There's also the Heart Failure Society, which is really good, that has good information. So, heart failure is the inability of the heart to pump a sufficient amount of blood to meet the metabolic and oxygen needs of the body. In infants and children, inadequate cardiac output is usually caused because there's a congenital heart defect, meaning they have a shunt, they may have an AV fistula, they may have an obstruction, or both, that causes them not to have good output. In infants and children, a combination of left sided and right sided heart failure is usually present. They have a little combination. The goals of treatment are to improve cardiac function, remove accumulated fluid and sodium, decrease the heart demands, and improve, of course, perfusion. Now, sometimes we may need to have surgery if you're a child and you have an AV fistula that has not closed, the ductus arteriosus has not closed in that heart, then the child won't have good cardiac output. Sometimes we'll wait on that to see if this child will, if that area will close in the heart. Sometimes we have to go in surgically and help that. Again, cardiac output is the heart rate times the stroke. Normal is approximately 4 to 8 liters per minute at rest. Adequate cardiac output is essential for correct tissue perfusion. So if there's a question on the test, what does it take to have adequate tissue perfusion? It means adequate cardiac output. If the heart's not working well, we don't have good tissue perfusion. So what is the ejection fraction? Ejection fraction is the percentage of blood ejected from the left side of the ventricle with each constriction or contraction of the heart. Normal EF is around 55 to 65%. However, if they've had a heart attack, you're going to see patients with lower EFs, and hopefully they're going to get that sometimes back. So we're going to look at EF. EF is stroke volume divided by left ventricular end diastolic volume times 100. I don't know if you're going to need that particular equation, but it's in my notes, so I'm mentioning it. Preload, though, I think it's more important to understand the terminology. Preload, that's the load that's on the heart inside the ventricle at the end of diastole, meaning it's at the end when the heart is supposed to be resting, and preload is that pressure when it should be at rest. And that is determined by end systolic volume. That's the amount of blood still left in the left ventricle after it has contracted, or the amount of blood left in the right ventricle after it's contracted. So normal values, central venous pressure on the right side, right of this heart, is 1 to 5 millimeters of mercury, because it doesn't have to have as high a pressure. The right side of the heart doesn't need as high a pressure to go to the lungs. However, the left side of the heart needs a higher pressure, so it's 4 to 12 millimeters of mercury. Okay, afterload. That's the resistance the ventricle must overcome to eject blood. For the left ventricle, systemic vascular resistance, and for the right ventricle, it's pulmonary vascular resistance. So the left ventricle has to be able to push against the pressures that are in the body. The right ventricle only needs to push against the pressure that's in the lungs, because it's needing to get the blood to the lungs to get the oxygen. So contractility, again, is the force that the heart must contract in order to get the blood to the heart, through the lungs, and to the body. So review your pathophysiology of the heart if you need to. Heart failure then occurs when there is a reduced ratio of ejection fraction to the left ventricle in diastolic volume. Okay, what does that mean? The heart is unable to meet the increased metabolic demands of the body because it can't pump high enough. So the heart is enlarged, it's become a little bit hypertrophied, it's not able then to supply the body and our organs what it needs as far as perfusion and nutrition. So what causes this? Okay, well, first of all, it could be a heart attack. If the person has had a heart attack, that means we've got blood that has been cut off to a certain part of the heart. Now we have a heart that has damage. The muscle's been damaged somewhere. So now we don't have the full, it's like having one tire on the car flat because the car can't get pulled if if it's got a flat tire somewhere. Cardiomyopathy, valve insufficiency, or a stenosis all can lead to our heart not functioning correctly. And then there's problems outside the heart that would be external. That would be because we have coronary artery disease, because we have atherosclerosis going to the heart muscle itself, not enough blood's getting into that heart. Or it could be because of chronic hypertension, because again, we're not treating, we're not getting our blood pressure under control. It could also be that there's too much pressure in the lungs. If there's too much pressure in the lungs and the right side of the heart's trying to pump into that lung to get the oxygen, then it's it's having to work too hard on that side. So we can actually see the right side of the heart be under that load. And of course, things like diabetes can also affect this. Okay, the result is overload on an otherwise normal heart. So anytime the heart has to work harder and pump against too much, that's what we're calling heart failure, okay? All right. So here's another description. There's a difference between left-sided. As you can see here, the ventricle usually is the left ventricle is very muscular, but this particular picture shows the walls of the ventricle has been stretched out. The heart is actually increased in size. Left side is the most common type of heart failure. It's the heart loses some of its ability to pump blood out of to your body after it's been reoxygenated. And this is usually caused by coronary artery disease, meaning that there's not enough blood flow keeping that muscle alive and functioning. And the ejection fraction can actually be less than 40%, meaning we're not getting enough blood out of that heart and it's not going to the body, so we're not perfusing. And then we have right-sided. Now that's where the right-sided of we've got blood coming back to the right side of the heart, but because it can't get to the lungs because of pressure in the lungs, pulmonary hypertension, then it's not able to pick up oxygen, get back to the left side of the heart as well, and then get pumped out to the body. So we have some patients who have both left and right-sided heart failure. So over time, the left ventricle dilates and enlarges when we have, again, weakened heart muscles, and it can't generate enough stroke volume or cardiac output. Blood backs up into the left atrium and pulmonary circulation. There we end up putting a load on the blood. Okay, we got an accident on the freeway. We can't get blood out of the lungs into the left side of the heart because, again, the body has too much pressure and the left side of the heart has enlarged and it's not able to pump. So we're talking again, 465 in Indianapolis right now. And that's where the heart is. It is in a freeway accident mode where we can only go 20 miles per hour at best. And very aggravating for the body, very aggravating for the heart that's driving us because they can't get the pressure up. So we talk about heart failure. We actually, you'll see the acronym HFpEF. That means that the heart failure has preserved ejection fraction, meaning the ejection fraction is normal. It's above that 45%. And then there's REF, which is reduced ejection fraction, meaning the ejection fraction is less than 45%. So, what happens when we have bad heart failure and we're not able to perfuse the body? And we do have some mechanisms that come to play. First of all, our sympathetic nervous system will try to release epinephrine and norepinephrine in order to increase the heart rate, which we see tachycardia. And then we'll see contractility also increase, trying to get the blood out of that left side of the heart. Unfortunately, the harmful long-term effects of that is increased afterload or increased peripheral resistance, where the heart works harder and harder, and it has a higher oxygen demand. And then we have risks of dysrhythmias, and then remodeling of the heart, and then, of course, cell death, and then, of course, the heart gives up. Then we have the renin-aldosterone angiotensin system, the RAS system, that also tries to get into play. It says, okay, let me see if I can't help this. So it decreases with decreases of renal perfusion, it triggers the renin to be excreted, which increases angiotensin 1 and angiotensin 2. And then that's going to cause increased problems with our afterload again. It's going to cause vasoconstriction, and so increased afterload. So the long-term effects, again, we'll see long-term overload, we'll see fluid overload, we'll see edema, we'll see the typical signs we see with heart failure as this heart no longer is able to function adequately. We'll see patients' weight go up. We'll see tissues that are getting boggy with fluid because fluid is not returning back to the heart where it can get offloaded and into the kidneys, and the kidneys are getting overtaxed. So as our left side of our heart becomes dilated and the muscle gets weaker and weaker and weaker, we're going to see progressive deterioration of the contractility of the heart. And again, the heart just cannot take the overload. Now, we may see an increase of antidiuretic hormone from the pituitary, which is trying to get the kidneys to kick in and trying to pee much more so we can get more urine, get more fluid out. And then, of course, natriuretic peptide, the brain natriuretic peptide is going to be, the heart releases that in order to try to promote sodium and water excretion, but then that levels go up, and that's why we can go in and do the blood test and look at BNP and see if that is high, and then we know that the issues with this is actually related to heart failure and not some other system. So what are the consequences, again, of inadequate perfusion? Think about that. Okay, we're going to have a brain that's not thinking. We're going to have kidneys that can't function. We're going to have a liver that's not doing its job. We're going to have problems with peripheral edema, shortness of breath. We're going to see all the signs and symptoms that are associated with classic congestive heart failure. Make sure you guys go to the New York Heart Association's functional classification and know some of these classifications and what the symptoms are of class 1, 2, and 3, and 4 heart failure. Just take a look at that. I'm not for sure if this is going to be on a test. It's a little bit higher level, but it's something I would want to know, if because the doctors in their notes will say this patient is in a NYHA 1, 2, 3, or 4, and that's going to tell you what level of functioning this patient has with their congestive heart failure. If they're a class 4, they're at severe limitations, but they're having symptoms of heart failure at rest. They're short of breath. They're sitting there wheezing. They can't catch their breath even when they're resting. If it's 3, then they're marked limitation. They may be fine at rest, but as soon as they start to get up and start doing something that's a little bit taxing, like walking to the bathroom, they get short of breath after a few steps. Definitely cannot go up and down stairs. Class 2, they are comfortable at rest. They're able to do some things, but they have to rest in between. And of course, class 1 is that limited activity. They're able to do what they want to, but they may have to limit from time to time. It's not as severe. We also have what we call the stages of disease progression, which is A, B, C, D. There is 1, 2, 3, 4, then there's A, B, C, D. So that is also something that the doctors will use as well in their classification of heart failure. So what are our general common signs of heart failure? It's fatigue, weakness, exercise intolerance, tachycardia. Pulmonary is dyspnea on exertion, then at rest. Orthopnea, that again is changing, that's shortness of breath with, changing in positioning. Paroxysmal paroxysmal, excuse me, nocturnal dyspnea. That means they can't lay down flat at night. They have cough, they have crackles, and they have dependent edema and weight gain. They may have jugular vein distension, hepatomegaly because the liver increases. They may have fluid in their tum-tum. You chap on their tummy and they've got a fluid wave going across the abdomen. So that's ascites. And then, of course, they get severely, with severe conditions, they get anorexia and nausea. So nothing is good with this. I think I lost my whole thing. I'm going to have to start all over. We're still recording. Okay, let's continue on here for a few seconds. I had to take a little quick break, turn on the lights because it's getting dark here at home. Want to review again real quickly our normal medications that we will see with heart failure patients. Again, we're going to see your diuretics, that's to reduce fluid overload. Then we have your ACE inhibitors or ARBs. That's going to block the RAS, reduce, and that's going to reduce afterload. So those two medications together. Now they use ACE inhibitors or ARBs, so either one. And then we have aldosterone antagonists, which block sodium and water retention. So it's very important to know these patients are on a lot of medications and they have medications that have a lot of different side effects with them. So we need to be able to evaluate, are the medications working? Do they have any problems with electrolytes or any type of sodium, potassium balance issues? Are they suffering from other conditions due to that, or especially if they become volume overloaded, is their weight going up? Volume underloaded, that means their weight is going down too much. So we need to make sure that we're doing a lot of teaching with these patients. When I worked in the congestive heart failure patient, I did my clinical assessments and teaching, but then I had a registered nurse. All they did was do education. And when we first saw these patients, the first appointment with our patients that were being referred to the clinic, they spent a good hour to hour and a half with us this very first time because we did so much teaching and we taught them how to read labels and how to um, define the differences of what good things to eat and what things they shouldn't be eating. So it was very important. So, classifications and stages of heart failure. Again, I've already talked a little bit about this. Make sure that you review the New York Heart Association's classifications, stage 1, 2, 3, 4 versus A, B, C, D. Yes, these possibly could be on your exam. Can't say because I haven't seen the final exam. So the possibility is that, yes, they could be on these. They may say, um, if a patient says NYHA 1, 2, 3, or 4, we know that then that is the classification. What condition does this patient have if they have heart failure? So I don't expect you to have to know everything about heart failure. I just need you to know about the processes and the medications that are used and how to recognize a patient that is having heart failure problems. So again, failure assessment, diagnosis, tachycardia, especially during rest and slight exertion, tachypnea, that's that fast heart rate. They may sweat. We may have fatigue and irritability, sudden weight gain, and respiratory distress. Again, we may be seeing blood work, BNP, NT-pro BNP may be done, as well as making certain that we look at congestive heart failure. Troponins are going to tell us, now this is one that's important. This one comes up on the HESI. What is a troponin test for? A troponin is a test that measures the level of a protein called troponin, and that is released when the heart or a muscle is damaged. If there's elevation to that troponin level, that can indicate the person is having a myocardial infarction, a heart attack. But it doesn't mean a heart attack alone, so we want to make sure. Again, we have our BMPs, CMPs, complete blood cells, stress tests. We may send this patient to the cardio group to have a stress test, and they put them on a treadmill, and then they see if they can how much stress the heart can stand. Now, there is, besides the treadmill test, there is a cardiosym test that they can give this patient to mimic that by giving them a medication. And that puts the heart into stress, and then they do studies looking at the heart. So here we have the left-sided and right-sided again. The differences that you'll see in some patients with PND, paroxysmal nocturnal dyspnea, elevated pulmonary capillary wedge pressure, pulmonary congestion, cough, crackles, wheezes, blood-tinged sputum. If they're having frothy sputum, that's a huge problem. Now, right-sided failure, this is the question that always comes up on the exam. This patient is exhibiting dependent edema, and they've had weight gain. They have a distended JVD. They're having ascites. Which is it? Is it right-sided or left-sided? If they say dependent edema, definitely right-sided heart failure is the answer to that. Are they experiencing right-sided heart failure? Now, if the left side, again, this the left side heart failure is that they're not pumping enough blood out to the rest of the body, they're going to have, again, tachycardia, exertional dyspnea, fatigue, and cyanosis. They may have some edema. They may have decreased blood flow to the digits and the external area because they don't have enough cardiac output. So very important for you to know the differences in the clinical manifestations between the left and the right. Again, fluid gain, we want to make sure that those patients are weighing, no matter if they're left-sided or right-sided heart. Heart failure diagnosis, again, we're going to be looking at an ultrasound. We're going to look at the size of their heart. We're going to do an echocardiogram. That is a quick, painless test that records the ECG shows us that, but echocardiogram is sound waves that create images of the beating heart, and it shows us the size and structure of the heart and heart valves and blood flow through the heart. So need to know a basic understanding of the definitions of these tests. Echocardiogram, basic ejection fraction, what is normal? It's above 50. If they have heart failure, it could be less than 40. So very important to know. Exercise tests, stress tests, CT scan of the heart, MRI of the heart, or cardiac MRI, coronary angiogram. Those are all looking at the blood vessels and whether or not the blood vessels have any restrictions, etc. And then, of course, the staging of the heart. So our medications, angiotensin, beta blockers, diuretics, boy, they really are hitting this in this particular presentation. They've hit this twice now. I would say knowing these medications is important. Interventions for heart failure is to have a heart valve replacement. If a valve is faulty, causing the problems, replace having a cardio defibrillator if needed. If their ejection fraction is less than 30 and they have heart failure, they're going to recommend that they get a AICD, which is automatic cardiac defibrillator or pacemaker, so that they make sure that they keep the heart going. They may have to have cardiac resynchronization. That is where they go in to make sure that the heart, if it's having dysrhythmias, they put it back into the correct electrical conduction. VAD, that is a device that we can put into the patient. It's basically implanted inside them. It is an automated heart. And that particular device allows us to actually beat for the heart when the heart's no longer able to beat. And of course, heart transplant. They may be on a VAD for a short time and then go in and have a heart transplant. So let's quickly go over Uh, in my notes here, I see that they've got the medications again listed here. They have angiotensin converting enzymes, which is your lisinopril and ACEs. They have the ARBs. They have them listed here: valsartan, Diovan, cardizem, or Cozar, et cetera. They have the ARNIs, which is Lintriesto. This is sacubitril and valsartan. Now, that particular drug that is usually started on a patient, they have to be monitored very closely, but they have to have the ACE or the ARB stopped. They cannot be put on that medication unless the ACE and ARB is stopped. Then 24 hours later, they're put on this med because it already has the ARB in it. And then we have to monitor them every few weeks, their blood pressure, and then they titrate that medication up until they actually get better blood flow. And it has really helped congestive heart. It has changed the game with heart failure. It is quite an interesting drug. Then you have your beta blockers, diuretics, potassium sparing diuretics, which we've talked about before. And then we have a new player on the block. It's the SGLT2, which is the sodium glucose transporter 2. That particular med is actually used in diabetes. Those are the medications Farxiga and specifically empagliflozin or Jardiance. They've got canagliflozin, but canagliflozin has been nixed. It's not being used as much because that one has a high incidence of amputation with it. It was the first drug that came out in this class, so it's not the one that has been showing. That particular drug does not show efficacy for heart failure. So concentrate on dapagliflozin, which is Farxiga, and empagliflozin, which is Jardiance. Those actually have good heart failure reduction and have actually increased people's longevity by 20%. And they don't have heart attacks as often because they're on those drugs. It's because that medication actually throws extra blood sugar out of the kidneys. So they're actually peeing out more glucose. And when they pee out more glucose, it also takes some of that water with them. So it actually reduces the water that they have. It acts almost like a diuretic. Now, here's the key thing for nursing consideration. If they're on SGLT2 and you do a urine dipstick, are you going to find glucose in the urine? Yes, indeedy. Are you supposed to in a normal person? No. But if they're on SGLT, go back and look. Are they on empagliflozin or dapagliflozin so that you know that, oh, it's that drug that's causing the glucose to be excreted. And then these patients could be also on digoxin. Again, digoxin is digitalis is another name. It slows the heartbeat. It allows the ventricle to fill completely, and then it increases contractility, allowing the heart to push more blood out. So it actually increases your cardiac output. Hydralazine and isosorbide dinitrate, that also is a combination medicine that helps relax blood vessels, and it's added to the treatment if they have severe heart failure symptoms. And that's especially if the ACE and the beta blockers haven't helped. And then we have Verquavo, which is the new heart medication for heart failure. It's Versiriguat. That medication is taken once a day by mouth. It's a type of medicine of oral soluble guanylate cyclase. In other words, this one here is for high risk patients who have heart failure. And it showed that these patients had fewer hospital stays for heart failure after they started this particular drug. This is one of the drugs that we were doing research on when I worked in cardiac research. Quite an interesting, that and dapagliflozin and Jardiance were the other two drugs that I've actually worked on when I was in research. So those are really great drugs. And then we have the positive inotropes. Those are given to people in order to also help with the contractility of the heart. So there's a lot of more play. We put these patients sometimes on oxygen, and then there's procedures. There's coronary artery bypass surgery, heart valve replacement surgery, implanted, again, cardiodefibrillators, ICDs and AICDs that we can do with patients, and then ventricular assist devices, which is those VADs that help pump blood from the lower chambers of the heart. If you haven't seen that, go search VAD, VAD. in YouTube so you can see this. It's quite interesting. These people carry around a battery backpack with them. Uh, and if that battery has two sides, you have to change one battery at a time out because that's all that's pumping their blood. That is their heart. So that is kind of interesting. Uh, Again, the goal of treatment for heart failure is to reduce fatigue, shortness of breath, reduce fluid retention, and improve energy levels so that they can stay active. To slow the progression of the disease, in 2004, when I first started at community hospital there, and I was going to take over the congestive heart failure clinic because we were doing research in the clinic. The average person with heart failure lived 4 to 5 years. Now people are living longer with heart failure. We're actually slowing the progression of disease. We haven't cured it, but we're just slowing the progression right now. If we can get people to change their lifestyle, though, and be more healthy, being more active, don't smoke, don't eat a whole lot of salt, keep your blood pressure low, then we wouldn't see heart failure. We could whip heart failure a lot. I'd say 30% of people who have heart failure have it because of other reasons, their heart congenital problems and stuff. But 70% of people that have heart failure, in my estimation of the patients that I took care of, it was all due to lifestyle choices. And it's sad to say they could have avoided that had they made better choices when they were younger. And again, if they had need heart valve surgery, we could do that, but that doesn't mean that that's going to solve their problem. And of course, heart transplant, that's for severe cases again. So, questions. Let's look at the questions. NCLEX practice questions. A patient with heart failure is prescribed digoxin 0.125 milligrams PO daily. Before administering the medication, what is the most important nursing action? Okay, now this drug slows the heart and increases contractility, so it's going to increase the contractility. What would be the most important thing that you should check? If you said B, you are right. Measure the apical pulse for 1 full minute and make sure it's above 60. Do not give digoxin if the heart rate is less than 60. Make sure you contact that doctor. Because if you give it and the heart rate is too low, you're going to decrease their cardiac output. In reality, you're going to probably cause them less perfusion and you're going to cause problems. A patient is taking digoxin, reports seeing a yellow-green halo around lights. What should the nurse do first? Now, we've not talked about digoxin too much, but we have talked about toxicity. And that this is one of those drugs that, yes, you need to make certain that we are monitoring for toxicity on this drug. Every now and then they need to have a blood test. One of the symptoms is visual disturbances such as yellow-green halos or blurred vision are classic signs of digoxin toxicity. We should hold the dose of digoxin, call the prescriber, and they will probably make sure that we assess that patient, see if they have a headache with this, dizziness and confusion and nausea. If they do, definitely increase their fluids, but that's not the first thing. We're going to withhold that dose of digoxin and notify the prescriber. Make sure we get a blood test to check for the digoxin level. That is a HESI question, and that I can guarantee you will be on your exam somewhere. The nurse prepares to administer atenolol, which is a beta blocker, to a patient with hypertension. Again, see the last letters, LOL. The patient's blood pressure is 88 over 54 millimeters of mercury and apical pulse is 56 beats per minute. What is the appropriate action? Now, remember, you're not a doctor, so don't be acting like you can prescribe, okay? So you need to look at these choices. Are you going to administer that medication as ordered? Because it's been ordered. Are you only going to give half the dose? Are you now practicing medicine? Administer the dose with food. Is that going to change anything? Nah. So C, yeah, we're going to actually hold that dose, notify the prescriber, and say, what do you want us to do? If the systolic blood pressure is less than 90 millimeters of mercury for systolic and less than 60 beats per minute for the heart rate, we definitely should be holding that, talking to the doctor and saying, hey, we've got a patient with bradycardia, or I've got, now either one of these would make me want to hold that. Their blood pressure might be 109 over 60 and their heart rate's 56. I'd still want to hold that because we're talking a beta blocker that's going to slow the heart. The action of beta blockers for the patient that has blood pressure issues is to slow the heart, allow the ventricles to fill so that when the heart pumps, it can have a full load so that we can get it out the aorta. That is what we're trying to do with that drug. Okay, patient states, I stopped taking my blood pressure medicine because I felt fine and it was making me tired. Now, beta blockers will make a person feel a little tired as well as calcium channel blockers. What is the most important information for this nurse to provide to this patient? Now, first of all, don't practice medicine. A, C, and D is you practicing medicine if you chose one of those. If you said B, that is the appropriate response. Listen, stopping suddenly can cause dangerously high blood pressure, and it's very bad for your heart. It's going to cause your heart to stretch. It's going to cause your heart to go into heart failure. So make certain that you continue your medication, go back to your doctor. Usually, I'm going to tell you guys, and I don't know if I would tell if I was the LPN, I don't know if I would tell them this, but I would get the nurse practitioner in there to talk to this patient. I would have them talk to them, or I would send them to their doctor so that they could have that to talk and explain that if hypertension is not treated, it is going to cause really long-term problems. It's going to shorten your life instead of living your full life and having a nice old age where you'll have your golden years and they'll be good years. And if you really wanted your golden years to be spent in the doctor's office all the time, don't take your medication. But they can change these drugs. And a lot of times with beta blockers, it will make you feel a little tired the first 2 or 3 weeks. And then after you get used to it, after you get your blood pressure down, then suddenly those symptoms start going away and you don't notice it or you don't feel it anymore. You don't have that tired feeling. You get your next burst of energy. So if they will stick with it, usually those symptoms will go away. A patient is taking an ACE inhibitor for hypertension, reports a persistent dry cough. What should the nurse do? Okay, we've talked about this at the beginning. We talked about ACE inhibitors and what their not normal, natural side effects sometimes is. Report the symptom to the prescriber is always appropriate in this because a dry hacking cough is a common adverse effect of ACE inhibitors. And it should be reported to the prescriber. It's so that they can determine whether or not they need to switch this person to an ARB. Because again, an ACE inhibitor has this side effect, but an ARB doesn't. And so they may tolerate the ARB better. So, yeah, advising the patient to take cough suppressant, that doesn't help. It's quite interesting. If you have a cough with ACE inhibitors, the cough suppressant doesn't even help. Document the finding. Yeah, you're going to document and you're going to reassure, but you're still going to report the symptom to the doctor so that they can address that. And then you're going to instruct the patient to take their medication with food again. Doesn't help with food. It doesn't change anything. The nurse is caring for a patient with left-sided heart failure. Which assessment findings should the nurse expect? Again, look at the wording, expect. So we know what to expect. What is our assessment going to normally turn up? Now, the first one, peripheral edema and jugular venous distension. That is going to be if they're having really severe heart failure or left-sided heart failure. Now, left-sided, again, this is left-sided. If it said right-sided heart failure, yeah, I would expect to see peripheral edema and jugular vein distension. This is a tricky one because they lured you in on the trap. They talked about left-sided heart failure and then they threw in right-sided heart failure symptoms on the first question or the first answer. They also threw in ascites and hepatomegaly, which is also right-sided heart failure. Not weight loss and decreased appetite. It's going to be weight gain. So the only one we're left with is dyspnea and pulmonary crackles. We would have shortness of breath and we would have crackles in the lung fields somewhere. Usually the base is if they're sitting upright. So left-sided heart failure leads to pulmonary congestion, causing dyspnea, shortness of breath, coughing, and pulmonary edema with crackles when we hear it. Right-sided heart failure causes systemic venous congestion with peripheral edema, jugular venous distension, ascites, and hepatic congestion. Got to understand the difference, folks, because this is the question that trips up people on the test every time. I'm stressing it, and I'm stressing it, I'm stressing. Know the difference between left-sided and right-sided. Okay, patient with heart failure is prescribed furosemide 40 milligrams PO daily. Which assessment is most important for the nurse to monitor? What is furosemide? If you said loop diuretic, you are correct. Loop diuretics do what? It causes significant potassium loss, so it's potassium B. We got to monitor the potassium levels and also teach patients about potassium-rich foods or supplements unless they're on spironolactone as well. If they're on that, then we just need to make certain that they're getting their BMP or a basic metabolic panel occasionally checked that will tell us what their potassium level is. The school nurse is monitoring a 15-year-old student with heart failure. Yes, children can have heart failure. Which behavior is most concerning? Now, I could tell you which one I may pick that one up because I've seen this and I've seen 20-year-olds do this and wonder why their heart is in such. I had a 36-year-old who died of a heart attack because of this very same reason. It's called Red Bull. Yep, experimenting with energy drinks and stimulants. It's the last thing this child should be doing if they have heart failure because energy drinks and stimulants cause increased blood pressure and cardiac workload. It can cause heart dysrhythmias and it can be life-threatening. It actually messes up the medications that this kid is probably on. The 16-year-old with heart failure states, I feel so different from everyone else. I can't do sports and I'm tired all the time. Sometimes I wonder if life is worth living. Yeah, what is the nurse's priority action? Now, remember your therapeutic communication. We're not supposed to just reassure, we're supposed to address seriously the concerns. And we have a child. What age group is it that we're really concerned about suicide? Yeah, B is our answer with this. Assess for risk of suicide and notify their healthcare provider. Um, we definitely want to make sure this person is getting into therapy, that they're discussing their feelings, because this is the same. If change this condition and put diabetes on here, yeah, you put any condition that a teenager has that limits their ability to be like other teenagers and they have the same feeling, they need to be assessed from time to time for risk of suicide. Again, 16-year-old with heart failure confides to the clinic. I've been skipping my water pills on weekends when I go out with friends because I don't want to use the bathroom all the time. What is the nurse's best response? Now, therapeutically, again, Let's talk to this person, discuss their risk of skipping diuretics, see if there is a compromise that we can make because we need to explain to them, yeah, it's important for you to take your diuretics. Can we change their time? Can we try different timings? Can they can we tell them or explain to them that yeah, sometimes skipping this is not the thing we need to do. You need to be taking your diuretics because it's putting your heart at risk. Apparently, this child is probably on the transplant list if they're having heart failure at this age. Okay, the nurse obtains blood pressure readings of 88 over 54 again. Is that high or low? Which additional assessment finding would indicate that this hypotension is life-threatening? Patient is resting quietly in bed now. We can get rid of that one. Patient's blood pressure is usually 110 over 70. Well, that's good. It's great to know that. A patient reports feeling slightly tired. Yeah, they would. But no, this patient has cool, clammy skin. That means their perfusion is down. They now don't have enough warmth on their skin and they have a decreased urine output. Hey, the kidneys are not working. That would be life-threatening. So clamminess, definitely. That diaphoresis, that's that pesky word diaphoretic again. That means sweating, cold sweat. A patient moves from lying to standing position, which finding indicates orthostatic hypotension. Again, this is your specific drop. Again, we're talking orthostatic hypotension. How much drop do we need? If you said 20 millimeters of mercury or more, yay. And they report dizziness. So that's going to be C. So definitely systolic blood pressure decreases by 25. A patient recovering from gastroenteritis with vomiting and diarrhea for 2 days reports dizziness when standing. What does the nurse recognize as the most likely cause? Okay, they've been vomiting, vomiting, and vomiting. Remember, vomiting reduces our acid, reduces our volume, reduces our water. We're we're going to be checking skin turgor. We're looking at their blood pressure. Yeah, we're talking dehydration causing orthostatic hypotension, especially. So make sure that they're drinking their fluids or at least holding something down. I know over the last couple of days I've had that problem. As you can see, my cheeks are nice and pink. If I'm still sharing my picture, I don't know if I am. It's hard to tell with this computer. But anyway, this is the end. I think this is the last slide. I greatly appreciate you guys hanging in there for me and going through this. It's important for us to continue um, learning together and making sure that you are able to uh, pass this course. It's very important. It's this final exam is important to a lot of you. Some of you are really close to, you know, it's kind of scary sometimes for me as your instructor to know how close some of you are. Some of you, you're going to be fine. You're going to do well on the test, and you're going to pass with 80% or plus. But those of you who are in that 70 to 75, you definitely have a little bit of a hill to climb. Make sure you're doing your EAQs. Make sure that you've done your homework, that you're getting everything in on Sunday. I'm going to post this so that you can have it in SurePath. Make sure you look at the whole thing. I have looked at the other videos I've posted out there. We've got both 8-week videos posted as well as the one that I posted because I missed my lectures at the end of the week because I was ill. And I can tell how many people looked at these videos. It gives me the information. It tells me that some of you guys didn't even look after 15 minutes. You were gone. I know my voice when I was ill was a little bit boring. Go through the notes at least, know the information, and then you can skip the lecture. Talk to you guys soon. See you in class.